Chapter 27 of the 2018 Clinical Practice Guidelines is on management of acute coronary syndromes. My name is Alice Chang, and I'm narrating this slide deck on behalf of the chapter authors Jean-Claude Tardif, Philippe Lallier, and David Fitchett. Key changes in this chapter for 2018 include a new algorithm for screening for diabetes in people with acute coronary syndrome but no history of diabetes. In addition, there are new recommendations on the use of Ticagrelor for people with diabetes with ACS at high risk of recurrent ischemic events. The checklist for acute coronary syndrome is as follows. Screen for diabetes in people with acute coronary syndrome. Use anti-platelet therapies, Prasugrel or Ticagrelor, instead of Clopidogrel in people with diabetes undergoing percutaneous coronary intervention. Avoid both hyper and hypoglycemia among people with diabetes admitted with ACS. This is the new algorithm for screening for type 2 diabetes in acute coronary syndrome. Upon admission, an A1C and a random plasma glucose should be ordered in all people with ACS who do not have a known history of diabetes. If the A1C is less than 5.5%, then this individual is considered normal, and therefore rescreening should occur as per screening recommendations, which would typically not occur during that same admission. If their A1C is 5.5 to 6.4%, then they should be considered at risk for diabetes, and rescreening should occur after discharge, again as per screening recommendations. However, if their A1C in hospital comes back at greater than or equal to 6.5%, and or the admission random plasma glucose is greater than or equal to 11.1, then we are suggesting that you start in-hospital capillary blood glucose monitoring, pre-meals, and bedtime for 48 hours. If all of the capillary blood glucose readings are less than or equal to 10, then the monitoring can be discontinued. However, if any of the CBGs are greater than 10, then institute strategies to maintain blood glucose between 7 to 10 millimoles per liter during admission. Now, the reason why there is a chapter on acute coronary syndrome in diabetes is because we know that the mortality surrounding acute coronary syndrome is higher amongst those living with diabetes, represented in the blue, compared to those without diabetes, represented in the pink. Interestingly, over time, though, as represented on the x-axis, the mortality has overall reduced as new technologies have become available. But regardless of that, the diabetes cohort continues to have higher mortality compared to the non-diabetes cohort. All people with diabetes and acute coronary syndrome should receive the same treatments as those who do not have diabetes, but there are some important differences which will further help those living with diabetes. People with diabetes have an increased risk of recurrent atherothrombotic events, including stent thrombosis. Low-dose aspirin therapy is effective for secondary prevention, and dual antiplatelet therapy is known to be effective as well. Diabetes infers an increased risk of recurrent atherothrombotic events, including stent thrombosis. Low-dose aspirin is therefore, randomized controlled trials have been conducted to determine if different antiplatelet therapies would be more effective. The Triton study was a randomized controlled trial of Prasugrel versus Clopidogrel on top of aspirin therapy in those with ACS and planned PCI. 13,608 patients were randomized, and at study end, it was noted that Prasugrel group had less primary outcome, which was a composite of CV death, MI, and stroke. This translated into a hazard ratio of 0.81 with a number needed to treat of 46. But what about the diabetes subgroup? In the Triton study, the diabetes subgroup included 3,146 patients. And as you can see on this slide, the amount of benefit was even greater in those living with diabetes. In fact, the relative risk reduction was greater at 30%, and the NNT fell to 21 because of the increased event rates. And thankfully, this was seen in the absence of any increase in bleeding. The PLATO study looked at Ticagrelor versus Clopidogrel on top of aspirin therapy in 18,624 individuals with acute coronary syndrome. In this study, Ticagrelor demonstrated less composite of CV death, MI, and stroke. Within the PLATO study, there was also a diabetes subgroup, and the diabetes subgroup benefited to the same extent. The overall population had a 16% relative risk reduction, which translated into an NNT of 56. Based on the data from these studies, dual antiplatelet therapy in people with diabetes and ACS is recommended, and either the use of Prasugrel or Ticagrelor in addition to aspirin is what ought to be used. Prasugrel should be selected if the patient is about to undergo PCI, is Clopidogrel naive, less than 75 years of age, greater than 65 kilograms in weight, with no history of stroke. Ticagrelor should be used if there is no history of hemorrhagic stroke and no extreme bradycardia. So either Prasugrel or Ticagrelor can be used in addition to aspirin therapy, and the selection would of course be individualized. And these agents should be used rather than Clopidogrel to further reduce ischemic events. Here you can see the comparison of antiplatelet therapies with Clopidogrel, Prasugrel, and Ticagrelor. They are all oral medications, some once daily, some twice daily, with different onset times, but the variability is greatest with Clopidogrel. So that answers the questions around dual antiplatelet therapy and which antiplatelets to select. However, another question is how long should one be on dual antiplatelet therapy for? The Pegasus study looked at dual antiplatelet therapy with aspirin and Ticagrelor for up to 3 years beyond the usual 1-year treatment. There was demonstrated reduction in cardiovascular death, non-fatal MI, and stroke with the Ticagrelor 60 mg twice daily dose with a hazard ratio of 0.84. Ticagrelor 90 mg twice daily was also assessed, and there was no distinct advantage. In fact, major bleeding was increased with the 90 mg dose, more so than the 60 mg dose. Patients with diabetes had similar relative benefit, but with 50% higher event rates, they had a 60% greater absolute benefit compared to patients with no diabetes, with similar rates of bleeding. And here you can see the results of the Pegasus study, with the orange and blue lines represent the Ticagrelor group and the green line representing placebo, demonstrating the reductions in outcomes over time. So that addresses antiplatelet therapy, but what about glycemic control among people with acute coronary syndrome? Hyperglycemia during the first 24 to 48 hours after admission is associated with an increase in early mortality in patients with ACS. Evidence supports the treatment of elevated blood glucose after ACS. However, the exact modality of treatment is somewhat inconclusive. The DIGAMI studies, both the first one and the second one, demonstrated that some glycemic control was better than no glycemic control. Patients with acute MI and blood glucose on admission of greater than 11 likely benefits from maintaining the blood glucose between 7 to 10. And insulin therapy may be required to achieve that, and it is very helpful to have appropriate protocols. Recommendation 1 for this chapter. In all people with ACS, a random blood glucose and an A1C, if not done in the 3 months prior to admission, should be measured. For people with a history of diabetes, this is helpful to identify individuals that would benefit from glycemic optimization. For people without a history of diabetes, this is helpful to identify individuals at risk for ongoing dysglycemia. If the A1C is greater than or equal to 6.5% and or random blood glucose is greater than 11, in-hospital capillary blood glucose monitoring should be initiated. If A1C is 5.5 to 6.4%, repeat screening for diabetes should be performed after discharge as per diabetes screening recommendations. Recommendation 2. In-hospital management of diabetes and ACS should include strategies to avoid both hyper and hypoglycemia. People with ACS and a random blood glucose of greater than 11 on admission may be treated to achieve blood glucose levels in the range of 7 to 10 millimoles per liter, followed by strategies to achieve recommended blood glucose targets long term. Insulin therapy may be required to achieve these targets. An appropriate protocol should be developed and staff trained to ensure the safe and effective implementation of this therapy and to minimize the likelihood of hypoglycemia. Recommendation 3. People with diabetes and ACS should receive the same treatments that are recommended for people with ACS without diabetes, since they benefit equally. In people with diabetes and ACS undergoing PCI, anti-platelet therapy with Ticagrelor, if Clopidogrel naive, less than 75 years of age, weight greater than 60 kilograms, and no history of stroke, or Ticagrelor, rather than Clopidogrel, should be used to further reduce recurrent ischemic events. People with diabetes and non-ST elevation ACS and higher risk features destined for selective invasive strategy should receive Ticagrelor rather than Clopidogrel. In people with diabetes and ACS at very high risk of recurrent ischemic events and at average or low bleeding risk, prolonged, up to 3 years post-ACS treatment with Ticagrelor 60 milligrams twice daily should be considered. In people with diabetes and non-ST elevation ACS and high-risk features, an early invasive approach rather than a selective invasive approach to revascularization should be used to reduce recurrent coronary events unless contraindicated. For people with diabetes with non-ST elevation ACS and complex coronary anatomy, coronary artery bypass grafting should be considered rather than complex PCI. In people with diabetes and ST elevation ACS, the selection of the reperfusion modality, PPCI versus fibrinolysis, should not differ from people with ST elevation ACS without diabetes. The presence of retinopathy should not be a contraindication to fibrinolysis. So key messages from this chapter include: over the past 20 years, the rates of acute MI in people with diabetes has decreased substantially. However, the burden of disease remains high because of the increased prevalence of diabetes. Diabetes and hyperglycemia are independent predictors of increased short and long-term mortality, recurrent MI, and the development of heart failure in patients with acute MI. People with an acute MI and hyperglycemia, defined as random blood glucose greater than 11, may receive antihyperglycemic therapies to maintain blood glucose levels between 7 to 10 millimoles per liter. People with diabetes are less likely to receive recommended treatments such as early invasive strategy and revascularization, reperfusion therapy, beta blockers, or dual antiplatelet therapy than people without diabetes. Efforts should be directed at promoting adherence to existing proven therapies in the high-risk person with MI and diabetes. Key messages for people with diabetes. A heart attack can manifest as chest discomfort or crushing pain, or as pain in the arms, back, neck, jaw, and even the stomach. Shortness of breath, cold sweat, nausea, and lightheadedness may also occur. If you are experiencing symptoms of a heart attack, you should seek medical help immediately. The faster treatment is started, the better. Thank you for your attention, and of course, to get further information on this chapter and others, please visit guidelines.diabetes.ca to use the interactive tools and to access further resources. In addition, download the app from Google Play or the App Store. Thank you very much for your attention.